Mullen, and we're very happy to have you with us today. Welcome. So today we have a very important topic to discuss, and it's very important to palliative care. And of course, in medicine, in all fields, if we have good understanding of ethics, bioethics, it gives us a lot of confidence in decisions that we make for patients. So I'm very happy to facilitate today for this discussion. And so we have today's topic is challenging ethical situations. And so without much ado, I would like to welcome everyone who could join today. And almost 40 of us are here with you. So I think we can start with your presentation, if you're ready, Michelle Mullen. Just a sec. I wanted to ask Megan, could you introduce Michelle to everyone? Or yes, you did. Okay, thank you.
Definitely, I'll do that. So I'm really thankful that Dr. Michelle Mullen has joined us. I'm really, really appreciative of her giving her time. Dr. Michelle Mullen is an associate professor of pediatrics and a consultant bioethicist at the University of Ottawa and the Children's Hospital of Eastern Ontario in Canada, in Ottawa, where I work. And Dr. Mullen has done so much to help us, not only at CHIO, and I've learned so much about how to approach these situations, like Dr. Romana said, from talking with Dr. Michelle, but also she has provided advice to some of the MSF cases that we've had, and has been teaching our pediatric palliative care fellows in the Philippines, in India, in Bangladesh. She's been so supportive of all of these efforts, and she's agreed to help us today and to really share some of her expertise. And it's a very interactive discussion and just thinking about how we approach these. And I hope you'll learn from her today. And so I'll hand it over to Dr. Michelle, and really so thankful that she's been able to join us. And as always, don't feel shy. Please put your questions in the chat and we'll get to them as we go. And Tasneem may interrupt and highlight a few points in Bangla as we go. Thank you, Michelle, over to you. And if you just say next slide, I'll advance the slides for you.
All right, thank you so much for that very generous introduction, Megan. And thanks to all of you for just letting me into your community a little bit today. It's a great privilege. Next slide, I think. Megan, next slide. So this is what I'm hoping to get through today. And I'm not sure where the cases came from. They're very interesting and challenging. We'll do our best to get through all of them. But just in terms of the didactic part, sort of the teaching part of this, I want to introduce a couple of ideas which take bioethics considerations and reflection a little bit past principalism, which may be the thing you've heard a lot about around at least Western bioethics, those principles of respect for persons. Some people want to call that respect for autonomy, but it's really respect for persons with two parts. One, that we do respect the autonomy where possible of persons who are capable of making their own decisions. But the second part of it is that respect for persons is that we have to protect vulnerable persons. So that's the part which often seems in North American discussions to be lost. And yet, because with children and young people and families, and also in the Canadian context with newcomers, refugees to Canada, Indigenous persons, really, some of those vulnerabilities are really a cornerstone. So I just want to highlight that. The second principle, and these are big words, which are really quite simple ideas. Beneficence means simply that we try to do good, that's obvious, and non-maleficence, that we don't do harm. And we know that in anything we do, pretty much that there's a good intent, even if we give someone a vaccination. Obviously, we do that to protect them from a serious disease. That's the good. And the bad that might come is that, you know, they may have a sore arm, they may not feel well, they may be fearful, whatever that is. So we try to have an appropriate balance of the benefits and the potential harms of what we do. And finally, the third principle is justice. And I wish that there were one unifying theory of justice, but I will tell you that there is not. I won't do a long explanation of that, but simply to say that for some people, justice means, well, if you can afford to buy it, you should. For other people, that might mean, you know, benefits need to be distributed equally amongst members of society. So there are many arguments about what justice really means, but what all theories of justice have in common is the idea that we treat like cases alike. So things that are the same, we make a decision one way, we've got to, you know, unless without a good reason, we need to keep doing that as we move forward, and to treat different cases differently. So that challenge, and this is a challenge in case analysis, is when to say, yeah, this kind of looks like a case we had before, but maybe it's different for an important reason. So how will we decide what is a relevant and important similarity or difference as we look through cases? So as I say, this is actually a US a school of thought. I think there's some value in principalism. I think it's not a magical formula. It is not an algorithm. And I think because of the context from which it comes, although it's been very powerful around the world, there are things that it misses. So I'm going to kind of move on from that. I think, you know, it gives us signposts for how we think about things, but we can go deeper and more richly than that. So there's two ideas that I will be introducing today, and I mean, they won't really be new to you, I'm sure. And one is called intersectionality, and that is how different layers of a person's characteristics or identity can affect their experience and how we need to proceed. And also very important in your context, the idea of trauma-informed care. And I'll come back to these. After I discuss those, I'm going to give a little rubric, kind of an umbrella of ideas that we might use. And I hope that if it is useful to you, that you can take it forward to help you as you're approaching cases to guide our case analysis. Because of the work that you do and its importance and its enormous challenges, I'm also going to just introduce the ideas of moral distress and moral injury. And then we will do our case reviews, and I'll try and leave you with some take-home messages. And that's kind of what we're after here. So Megan, if we could get the next slide, please. So intersectionality, this is a word that was used first by an African-American lawyer from Columbia about 30 years ago. Intersectionality, she says, is a lens, so a way of looking, a prism for seeing the way in which various forms of inequality operate together and exacerbate each other, so how they can make each other worse. And she talked about this initially in the context of race in America. And she said, we tend to talk about race inequality as separate from inequality based on gender or class, sexuality, or immigrant status. And what's missing is that how often some people can be subjected to more or even all of these, and the experience that they have in the world, in our society, is just not those things added together, but in fact that they act together in complex ways that if we want to treat people respectfully and with justice and to do our best, we need to take account of this. So I think when we talk of populations which are, arguably or at least potentially vulnerable in a number of different ways, and that can be immigration status, it can be national identity, ethnicity, language, many, many things that we need to take account of how this for an individual or their family or their community is affecting their experience as we try to provide care. So next slide, please. So I'm going to get to my little case checklist. And just to begin with this, I wanted to introduce the idea of trauma-informed care, a trauma-informed approach, which I'm sure is often appropriate, and you're probably doing this. So really what it means is, there's these kind of 4 R's to help us along. To realization about trauma, that trauma is something which is not just an event, but has this aftermath, which can be manifested in many ways in individuals and families and groups. So manifested in terms of behavior, communication, physical experience. The interaction with authority is particularly an important issue. To recognizing signs of trauma. And these I'm sure you're very aware of in the work that you do. And in this context, then having a system which can respond to trauma so that we recognize it and we know we begin to find ways to try and ameliorate that trauma. And finally, to resist re-traumatizing people, because we certainly know that in the way that we provide care, particularly under really difficult circumstances, we can re-traumatize people. And whether these are because people are dislocated from family, whether they've been physically or sexually experienced violence, in a variety of ways, that we need to not make things worse. So obviously we probably could have spent the entire evening talking about trauma, but just to say some things that we can take going forward is, how do we approach this? How do we mitigate trauma? And I think a couple of key ideas are, first, that the things that we know help traumatize persons and groups are around issues of giving them control back to their lives. So, and that might be their bodies or their privacy or their family. So control, and also consent. And that's a consent to be spoken to, spoken about, to be touched, to be treated. So I think that those are the really, really powerful first steps, are around control, giving it back, helping people take it, and helping them to have the energy and the space to consent to how their lives move forward. And obviously in the very constrained environments that you're working in, this is really challenging, but really critical in terms of giving the very best healthcare, and also to beginning to address the issues of social justice. So on my case checklist, we start saying, is there trauma here, and how are we going to recognize it and mitigate it? The second question, are there issues of intersectionality? And I find that for myself, when I'm working with case consultations, in particular communities, we can be naive about others' experiences in terms of to identify people in simplistic ways, to say, oh, this person is from this culture, they're Rohingya, or they are a Rohingyan woman, or, and to add these, but to kind of, atomize people, to make them very narrow. And intersectionality requires us to think that, to kind of put aside some of our assumptions, to say, well, just because a person has this religion or is this gender, or for this political affiliation, we can't assume things. We do have to see people for the dignified individuals who are worthy of care on themselves, and really see who they are, and let them tell us who they are. It used to be said that there was a golden rule, which is that we treat people the way that we would like to be treated. And I think that intersectionality is a place where we might use something called a platinum rule, which is we treat people the way they want to be treated. So that's, it's a step forward, not the way I want to be treated, but the way that you might want to be treated. As we go forward in our decision-making, in our case analyses, obviously, and this is a kind of beneficence and non-maleficence part of principalism, I guess, what are the risks and the costs of what we're proposing, or our options, and what are the benefits? And to whom? Who is risking and who is benefiting? because we know that, often our individual patients are situated within families, they're situated in responsibilities in a social context. So who benefits and who wears the burdens of the decisions and our approaches? My next step is to say, is our plan of action that we're thinking about now, is it fair? And is it equitable? Are we treating people the same way for the same kinds of indications? And we will return to that when we look at the cases. Could I have the next slide, please, Megan? My next point is, and it's kind of related to all the other things, but it is in itself an area of increasing bioethics interest and scholarship, and it is narrative. And narrative is really about stories, and a narrator is a person who gets to tell the story. So in bioethics and in healthcare, we know that in some ways we as healthcare providers tend to own the stories. We say that, well, sorry? Okay. This is what's happening with this patient. We are recording a story in the health record or the medical chart about, what the presentation is and what the interventions are. But really, well, that's actually not the story of the person who's living that or their family. So one of the things, and this is, again, speaks to the issues of trauma, speaks to the issues of intersectionality, are we actually hearing stories from those who are most effective and most concerned with what's happening? Next, in your context, I thought it was really important to think about something which I'm sure is an ongoing challenge, and that's, many of us, by virtue of our training, we can think of the ideal solution to a given problem, and the ideal solution from a kind of healthcare, scientific reductionistic perspective. But often the ideal solution, and we do see this in the cases, is something that might not be available or not be available in a full way in the context of constraint that you're working with. And again, with marginalized groups in vulnerable situations, this is often the case. So how do we kind of compare what we're going to do, and how do we manage that relative to the ideal solution that if we were somewhere else and could throw a lot of resources at a situation, what we're doing, and how do we manage that disconnect? My next point is about who else is involved in the problem solving. And, I'm saying this not entirely naively. I know that your resources can be very constrained, but certainly, one of the issues around doing ethical work is first of all, that you don't have to really take all of the burden on your own. And we get better answers when we involve others. And that may be others from the team, others from a family where possible, others from a community, to help us get to the right place. So where is the discussion happening? The next point is of concern, especially as we work with communities that may not be our community of origin, is to consider how our values and our experience might affect how we see things and what we want to do. And particularly as we work with persons who may have different religious beliefs, different political beliefs, different cultural affiliations, different ethnicity, different language. It is important, I think, to not go to our quick reaction to a situation and say, oh, I know what I have to do here. And it is an interest, there's a school, there's an area of research which impacts on bioethics called moral psychology. And it's very interesting that most people, if you ask them how they make a moral decision, they will tell you something like, well, if I see a situation, I think about it, I look at the costs and benefits, I look at what values are promoted or not, and then I make an ethical decision. But the reality is, if we study this, and it has been extensively studied, that what most of us do is see a situation, and we make an immediate snap judgment and go back, and then sort of go back and post hoc say, well, the reason I feel this way is because of these things. But we really don't do the analysis first, and that's not you or what it's that's how most of us. And unless you kind of bring a conscious effort of deliberation, it is very hard to not be very much guided by that initial gut response. So, you know, we have personal work, and this is both the challenge of doing ethical healthcare. It's also the really, in some ways, a really interesting and personally developing part of doing healthcare as well. And then finally, I always think when we have a plan, we think, well, like, what are the goals of the plan and how will they be assessed? And for me, one of the most challenging things, no matter what the context, when I'm doing a clinical ethics consultation, is for some reason, until they get to know me, people think that, well, I must have like a magic answer that I will pull out of my moral hat to say, well, this is what you must do, and then walk away and it's all sewed up. But really, bioethics and ethics, decision-making is the same as what we do in all of healthcare, which is we do the very best decision and make a plan today or tonight, and we see what happens. And if things are not working well in an hour or a day or a week, then because we're consistently assessing, we see, well, where do we have to do something different, or are there other options? So really, it's no different than trying to treat an infection or help a bone to heal or someone recover from surgery, whatever it is. We in an ongoing way, keep looking at what's happening and whether the decision we made is actually helping or not. So next slide. Thank you. I haven't been on a plane for a long time with COVID. That's okay. But I use this slide because I really want to emphasize, as you're trying to do this really important work, that you have to take care of yourself, and you have to take care of yourself ethically and morally. Because really, literally, and the slide shows that, when you're on a plane, they always say, if they're in trouble, put your own mask on first, so that you can keep breathing, that you will be all right. And then you can help the person who needs you, in this case, the child who's beside you. And you pay a price for the work you do. So really, this is why I wanted to talk just a little bit about moral injury and moral distress. Because without this, and it's not really just being nice to yourself, although you should be nice to yourself, it's also about taking care of yourself as a resource to continue to help others and contribute to the communities you're doing so much in. So next slide, please, Megan. So moral injury is something which is a state of profound psychological distress, which can result either from actions, things that have happened, or things that did not happen in a particularly important and charged situation, which violate your own moral code. And again, this is, if you remember, I did say we need to know what our values are as we come to work in complicated situations. The sorts of things that can contribute to this are what they call acts of perpetration, so things that are done, acts of omission, which are the things that we don't do or fail to do or can't do or prevented from doing, and the experience of betrayal, that sense that we can have that leaders or trusted others or governments or NGOs, whatever it is, we're not there to help or to support or even in peers. So this is very, very, this is a very big problem, and it's a common problem. It's not PTSD. It is not a mental health condition. But that said, it is something which certainly these moral injuries from a particular situation or experience can lead to very negative thoughts of shame or disgust. And these may of themselves be the antecedents or the things which lead to depression and anxiety. Much of the research on moral injury comes from the military, and you might think that's probably an easier way to understand from how actions or lack of actions have terrible consequences. But more recently, and especially a lot through the global pandemic, there is recognition of moral injury in healthcare workers. So this is something which you're at risk for. So that's why we bring it up. Next slide. Moral distress is slightly different. It is a psychological state where what you perceive as a healthcare provider as the ethically correct thing to do, and that, remember, that comes very much for many of us from the context of where we received our training or where we grew up and what was available. When it is different from, when that is what you think is ethically correct care and the level of care is different from what you are tasked at, that could be sort of told to do or able to do because of circumstances. This is something which has enormous costs over time, potentially, in terms of psychological and mental health, and also people leaving positions and leaving professions even because of the moral distress, that they experience. And it is something which is very significant in retaining staff in various contexts. And it is also something which can result in serious cognitive dissonance, and that really is around the idea of the effects that we have by being in our roles are quite at odds with what motivated us to be there. So I wish that I had a magical answer to both moral injury and moral distress, and I don't, but I do know that it is possible to build some moral resilience. And really what this requires, and I started off with the self-care, looking after yourself, but self-regulation and self-awareness. So that is really almost a space, and however that different people do this different ways. Some people might use meditation to do it. Some people may use talking to mentors or close colleagues, but to really help identify those things which are provoking moral distress, to ask about them, to negotiate our steps as we move forward through a case, bearing in mind this. And ultimately, one of the things where we suffer moral distress, where I think we both honor the persons that we feel we wish we had done better for, and we hopefully make things better, is that we take this into our advocacy. The distress, we turn it into some form of advocacy, so that we could try to build something of a better future. But this is, I don't want to be childish about this. This is a huge problem, and it requires enormous efforts to try and manage these so that we can go forward and continue to do important work. So I think from there, maybe I'll just stop and ask if anyone has any questions before we kind of get to the case part of what we were going to do. Are there any immediate questions? Okay. If not, then I think that maybe we'll go to the next. Oh, sorry.
It's all good. I was just typing if anyone had any questions or any clarifications.
Cognitive dissonance, can you give one example? I mean, besides.
Sorry, an example of
Cognitive dissonance.
cognitive dissonance.
That's a hard, maybe a new word for some of our participants.
Yeah, no, and it's not an easy concept. The best experiments about cognitive dissonance were actually done, and this might sound silly, but it kind of helps with the concept. Many years ago, mid-20th century, where psychologists did lots of work with rats. And what they would do is they would train rats to, if they, like in a cage, to go, and if they pressed a button, they would get food. That's how they learned to get their food. But then they introduced
Pavlov's effect, kind of.
Yes, But then they introduced a second step, which is that after the rats learned that's how you get food, that when they to go across their cage to press the button, they would get an electric shock. So that's cognitive dissonance. To do the thing which is right and which you need will cause you pain. So it's, I think it's easiest to understand in a rat, but also if you think about it in your work, to do the thing which is right, one has to sacrifice something, and you make choices which are not, they're not reasonable choices in a sense to do the work that you want to do. So which way do you go? So that's the dissonance, right?
Thank you very much.
Yeah.
It's clear now.
Welcome.
Thank you.
Thank you.
Is there a Bangla translation of that? Does anyone have like that idea?
I can translate what she just, Dr. Michelle just explained. So cognitive dissonance মোটামুটি আমরা বুঝতে পারি এভাবে যে আগেকার দিনে, I'm just going into Bengali. So
Thank you.
আগেকার দিনে আমরা যখন পরীক্ষা করতাম ইঁদুর দিয়ে, র্যাটস দিয়ে ল্যাবরেটরিতে নানান টেস্ট করা হতো, তো তাদেরকে ট্রেনিং দেওয়া হতো র্যাটদের, ইঁদুরকে, যে তারা যদি এক জায়গায় গিয়ে চাপ দেয় তাহলে খাবার পাবে। তো তারা সবসময় তখন ওই ইঁদুরগুলো ওইদিকে যেত, গেলে তারা খাবার পেত। এটা তো একটা ভালো জিনিস, তাদের জন্য সুখকর একটা জিনিস। পরে যেটা করলো ওরা, ওই যে যেই কাজটা করলে খাবার পেত, সেই কাজটা করার সময় ওখানে চাপ দিলে আবার শকও খেত, মানে ইলেকট্রিক শকও খেত, খাবার পাচ্ছে শকও খাচ্ছে। সুতরাং এখন একটা প্লেজারেবল জিনিস, যেটা আপনার ভালো লাগে সেটা আপনি করছেন, কিন্তু আপনার কষ্ট পাচ্ছেন। তো এই যে একটা আমাদের মাইন্ডসেট, মনের মধ্যে যে একটা যে অবস্থা দাঁড়ায়, সেটাকেই কগনিটিভ ডিসোনেন্স বলছে। ভালো লাগছে কিন্তু কষ্ট পাচ্ছি, এরকম অনেক সময় আমাদের জীবনে হয়। সুতরাং এটাই উনি বুঝাচ্ছেন কগনিটিভ ডিসোনেন্স। থ্যাংক ইউ ভেরি মাচ।
Thank you, Ramana.
Thank you.
So I think that we will move to our next slide, which is our case. And this is, I will read through the case, and then maybe I'll just invite comments after that. And I have a few ideas that we will get to about each of the cases. The first is a case of a premature baby. So I'm just looking at, okay, so the baby is 650 grams, a gestational age of maybe 24 weeks, so very young, who was born in an MSF hospital and admitted to their neonatal intensive care, which had only basic facilities. The team decided not to do any advanced resuscitation and to focus on comfort care for the baby. And I'm assuming that it was not possible, that there was not, these sorts of babies would often need ventilatory support, and they had risk for many, many things. But there was a concern about, if the baby does survive for a few days, should we feed the baby? Should an NG be placed to give express breast milk? There already was an IV intravenous in place, and fluids were being given. And what should be done? Should this be continued? Should it be left there? Should we restart it if it comes out? And a question there was if we don't give hydration, will the baby not become hypoglycemic? So I guess this is a case which picks up on a number of the concerns that, or kinds of issues I mentioned. I think certainly one of them, context, where people there would have felt that in a different environment they could have done different things. And so how do we move forward knowing what we have today or now in this context to help this baby and this family? What should we be doing? So I'll put it out to the group and ask if people have ideas about how they might think we should proceed with looking after this little person.
It depends on many things. If shall I start, or we should get?
Yes,
Okay, so this is neonatal ICU setup. Looks like at MSF hospital. Now there are number of things. We have to know the family. We have to understand the parents' mindset, not
Um,
just looking at the baby and the gestational age.
Ma'am, sorry for interrupting. Tasneem here.
Yes.
Ma'am, may we get some insights from our participants? Like they can write in the chat box, according to them, what should be the answers, or they can raise their hand. Then you can give a very good summary how you
That
see
can also,
this. Yeah.
That can also
Thank
happen.
you, ma'am.
Yeah, why not? Yes, please, most welcome. Anyone?
এই প্রশ্নগুলোর উত্তর কেউ যদি বাংলায় অথবা আপনি যদি কথা বলতে চান আনমিউট করে বলতে পারেন এবং লিখতে পারেন চ্যাট বক্সে। ধন্যবাদ।
And remember that there's not just one right answer, okay? So that's why we bring these cases. I think Dr. Michelle has taught me that it's okay to say something and it just is part of the ideas that we talk about. You don't have to know exactly there's no absolute truth.
It's a very good case. And I used to work at SCEBU, and we used to come across this kind of dilemma. And I was not trained in palliative medicine or counseling or breaking bad news. It was distressing for all of us. So it's so important to know how to talk to parents and how to be, in communication was so important.
I see Dr. Nazmul has raised his hand. Maybe Dr. Nazmul and then Dr. Iftikhar. Go ahead.
Thank you, Dr. Mullen. Actually, I'm not a doctor. I'm a medical assistant. Currently, I'm working with MSF critical project. I think you know about that. This baby is only 650 gram weight, and baby at this moment stayed in the NICU. Previously, we started IV fluid in the beginning time, but if the patient, we want to survive this patient few more days, and that sense, I think we have need to, we should do NG feeding and give the NG feeding for the survive the rest of the day. I think NGTV is another option, and we can start also IV fluid for removing the hypoglycemia. In the interval time, I will. In the meantime, in the feeding, we are giving the few minutes or few hours later, but we can give the feeding and that's the patient and maybe gone to the hypoglycemia. And that's why I think both are required in the feeding and also IV fluid.
Thank you. So did you catch that, Michelle? So what Nazmul has said, he's a physician assistant, and he said that if we give NG and IV fluids, and that will prevent the hypoglycemia and allow the patient to live longer, maybe 3-4 days.
okay. So that's really true. And so it's an important part of what now I think that whole, like, what are the goals of what we're doing? And someone had put into and it is true, the baby would become hypoglycemic at some point. Really helpful to know what the family wants to do. And that's, I think that was Erin Das. Thank you for that comment. They may want to take the baby home. And is this an option? I certainly, from an ethical viewpoint, would believe that it is an option. And someone is saying, yes, restart IV. Okay. So here we are seeing actually the differences in how people might value things. So, we have one view, which is like if the family wanted to simply bring the baby home and comfort them and introduce them to their family, maybe do whatever else is appropriate culturally. and other people saying, no, we should do everything we can to, even if it's just a few days, that every day is valuable. So here is, these are great examples of where values are kind of hitting against one another. And someone, I think from, Tasmin, I think is translating, is that? Okay, sorry. Thank you so much, Tasmin. So
I think we have a
yeah.
couple more hands up. Is it okay if I call on those
Yeah,
people? Because I think might be nice. So Dr. Iftikhar,
Yes.
go ahead. What's your thoughts?
Yeah. Okay. Thank you for Michelle for your case. Actually, for this case or for this baby, at first we should counsel the parents about the fate of the baby. Actually, what is the maybe the fate is maybe the bad fate, or it even is a good fate. It's both possible for good and bad fate. And after that, it is in the NSU basic facilities. It's not the advanced facilities of NSU, as I know in MSF hospital provide. Actually, uh, if the baby, I'm answering the first question. If the baby does survive for a few days, should we feed him? Yes, from my side, I should feed this baby, but not actually rapidly, because this baby is not prepared for tolerate the actually the feed. But we should wait for a couple of days, and after that, when the baby is stable for respiratory and cardiac thing or vitals also, then we can start the feeding. And yes, we should place a ANG. We can start a little, and after that gradually we increase the feeding. If the baby is tolerant, then we will gradually increase the amount. And after that, an IV was placed already, and IV fluids are given. What to do? We should actually divide the actually IV fluid and the express based milk through the. It's at first we should give the 100% IV fluid, and after that 2 to 3 days we should decrease the IV fluid is 20%. Then we can add the actually 20% in the feeding, and after then day by day it will gradually decrease the IV fluid and gradually increase the feeding. And if the IV should we restart the IV if it is displaced? Yes, of course, we should place the IV, because if anything happen in the feeding, because this premature baby intestine is not prepared for the tolerating the feeding, so we can aware of this because sometimes this premature baby, sometimes they will face hypoglycemia, so we should place IV. If we don't give any hydration, won't he get hypo? Yes, of course. This baby will hypoglycemic at any time, so we should check the actually glucose level at a regular interval, and should feed accordingly. Actually, what I said before. Thank you.
Okay, thank you. And so here we're seeing like another view, which is, although if I'm understanding correctly, that the prospects for this baby may be very small, that there, if there is some hope, then we should leave the door open for, for things to turn around, because, and it is true, these things can happen. I'm just, right, yes, okay, so thank you, Erin Das, again for that. Yeah, that, and this is where these great challenges, that it is, we can do many things and have a bad outcome, but we also have the fear, if we don't do enough, that we have not managed the opportunity to give this child and a family a chance. And I'm hearing, I'm seeing here from Rachel Yancey that it is unlikely, which is sort of my understanding. And I'm not a neonatologist, so I didn't know, but I assume that from what I know from even in our units here, that this child would be very precarious, their survival. So someone's saying they would avoid most life prolonging interventions. So here we have, so I feel that this is beautiful that we have all these people around the electronic table here, and you're bringing these clear visions of what is possible and what you think is appropriate, and we're discussing them. And this is how we work together to get through these decisions. Someone's saying, we'll call you beautiful. Okay, so I'm going to go to the next slide. I had see what I said about this. If I could have the next slide, Megan.
Sorry, here's your next slide. Apologies, lots of comments going on. I know Dr. Miradil wants to speak, so we'll get him in a second, Dr. Miradil.
Oh, well, no, you know what? He can go ahead. He can go ahead.
Do you want to go ahead, Dr. Miradil? I know you've had your hand up for a while.
Yes. Okay. Thank you. Hello, Megan. So,
Hello.
okay, my fellow colleagues are everyone giving their valuable opinion regarding their the clinical experience, and also I think this BCS on this the case, the very tricky hints is the basic NICU support. So, what should we do in the should we can do in the basic NICU support? So that's why there is several modalities, but regarding all that, of course, we ensure that try to best our, and in this type of source limiting contest, we should also go for we need to think that what will be the prognosis, because of this seat might be very much important for S1 also. So we need to think about every perspective also, and we also counseling the family, as some of our colleagues says, and so we respect all the things, and then after we can take a decision whatever we need to go. So I think no need to say anything about the regarding clinical perspective, because everyone already told many things about that. So there is the different modalities for treat in different way. So in this case, we need to also see the prognosis, that what will be the fate for the baby. So we need to consider also that. Thank you.
Absolutely. Thank you so much. You're absolutely right. That is, and as part of, our, what are the goals of care? Just, what do we think we can accomplish? When I look at this case, the first thing I thought of was just generally about artificial nutrition and hydration. And this is life-sustaining treatment. And of course, in a theoretical way, artificial nutrition and hydration is no different than renal dialysis or, pulmonary ventilation. These are artificial means of keeping persons alive. Now, that said, it often feels different. And this is something that in my experience, I've seen across cultures. There are very different viewpoints and understandings around this. For me, a third layer is that, and I think this is common in many cultures, that we have this sense that, we feed children, we feed babies, and it's very instinctive. No matter where you're from, that when a baby cries, we wonder, like, are they hungry? Like that. This is what we do, our sleepless nights with our new little babies. So this is a very strong human impulse. So what do we do with it? So what are the modes of artificial nutrition and hydration? And they kind of go from, pretty low tech, like to give a baby a bottle is artificial nutrition, right? But we don't really, any of us see that as being morally problematic, because it mimics, in terms of getting nutrition and the action of the baby, the bottle taking a place of the breast, that this is very easy for most of us. Moving to an NG kind of takes it up a little bit. And some people say, oh, it's nothing to put one in. We do know that in other circumstances, an NG, if it's long-term, can be difficult to maintain. There is the risk of it not going where it should be, and aspiration problems. So and certainly it's hard to know. We certainly use them all the time in little babies. We do know for people who are bigger, often children and adults really don't like NG. So, so it becomes a bit more of a burden, a bit more risk, but certainly a relatively low-tech way of providing nutrition and hydration and medication as well, which is valuable sometimes. IV support. Now, this is something which, again, it was, like another step, invasive, may become dislodged, may become infective. Then surgical interventions like a G-tube. We're coming much higher tech here doing this, or GJ tube. And then finally, TPN, which is something we do use in babies in Canada sometimes. We know that it's not, for the most part, a long-term solution. Just because of the invasive nature, because of the risk of infection, because of the impact on the liver and liver failure. So there's a whole spectrum. So where does this fit in? And as we go forward, what are the risks? What are the benefits and what are the burdens? And we'll see this in another case that's going to come up. I think it's the next case, that there can be burdens to the child, but also to family and to communities. Cultural considerations are really key here. And that's, so part of that is, again, knowing what we bring to the discussion because of our own beliefs, but also what our patients and their families, what they bring. And in some cultures, it is my understanding that insofar as possible, there's a drive, a need to try and provide nutrition as much as possible to the very end, that this is almost a religious, or it could be a religious sort of belief. And I'm going to return to that in a moment. Again, I'm going to say here, I'm not a neonatologist. A question I would have if I were dealing with this case would be, what is the potential for comfort here that might be derived by something, providing some kind of nutrition? And I don't know, at 24 weeks, someone might just say to me, this would never happen. But, there certainly are, I sometimes do see with babies, funny things happen around if they're offered either express breast milk by bottle or some liquid or formula that in fact they will take that. And it doesn't have to be, if they can't take enough to grow and sustain, if it is something which comforts them, then that should be offered and made available. So, and I think there was a last comment in the chat, or next to last comment in the chat, about how there's belief that this child would not survive. So, and again, we've heard different comments around the table here about whether there is any hope or whether that's just not realistic. So, my proposal would be, we need to know what the family wants. We need to really look very critically at the benefits and the burdens of these interventions, because if, for example, it is most likely that this child, or certain that this child will not survive, this little baby, and the family would love to bring them home, then perhaps we teach the family how to keep the baby comfortable for as long as possible, what that might look like. And whether that's mouth care, whether it's offering a little bit by mouth, or other interventions, so that there could be a bringing of that child into the family. And I did I can't recall, I'm sorry, names that someone had said that maybe we have to give this baby a chance. And you know what? If someone says, well, we're just going to offer a little bit of mouth something, but suddenly you've got a baby, and I have seen this happen, not in this context, but with babies who were not supposed to be able to drink, suddenly are taking down bottles, and we thought we would limit things. It's like, wait, you know what? Things have changed today. This baby is bottling, so we're going to see what happens. And of course, you would never hold back that kind of nutrition from a baby who was seeking it. So I don't know if that makes sense, but any final comments before we move to the next case? Okay, I think we'll move on to the next case.
I have just one question. In the context, in this MSF hospital, would the family have been able to stay and almost feel like a family in an NICU context? Because that is an interesting kind of dilemma. Is the baby kind of felt like they're part of the family, or is it like really separate? They don't actually have any opportunity to make a relationship with the child? Because I wonder if that would also begin to affect how the family decides what to do.
Right. Okay, so someone's going to answer that because I can't. This is Rachel.
The question is whether there is a space for parents to be with the child.
Yeah.
In NICU, usually in Bangladesh, where I worked, there was not enough room for parents to be inside. We had different small incubators and cots in other side for step down care. That was the unfortunate, but mothers, they had access to the baby, of course, reasonable.
Regarding the Rachel already answered.
Rachel's given her answer, someone's saying. So Rachel has said
Yes,
that yes, they could
in
stay.
Gualmara setting, they have the opportunity to, at least the family, mother will stay with the baby that time. Gualmara that have the opportunity. I think Rachel already answered that one in the chat box.
Right. Okay, so Erin, thank you all for commenting in on that. And Erin, it's a great question because obviously it's morally relevant, but it's also, it really helps underline that idea of context, you know, because if a family can't be with their baby, maybe that changes the picture enough that they want to take the baby home. But if they can stay safely within the context, then that's a wonderful resource. But it may not be in every environment that you may find yourselves working. So absolutely beautiful point. Thank you. I think we'll move on to case 2, which was, I think, another baby case. Sorry. And this is a baby with congenital heart disease, a 5-month-old with transposition of the great artery. So this is cyanotic congenital heart disease. In the context, there are no surgical options available for this little girl. She's now showing heart failure with moderate work of breathing, and she's cyanotic. So she's a bit blue and needs oxygen. The team is trying to access morphine to support comfort. So this is clearly, whatever the circumstances, quite constrained circumstances. And the comment was that it's very challenging for the team to deal with this, knowing that in other situations there would be more treatment available. And of course, I looked at this and we do surgical repairs on transposition in babies, all the time. It's a big surgery for the family, but it's not considered a big surgery in the unit. And most of these kids do so well after corrective surgery that it is very sad to see this, and yet it is a situation. So I'm just wondering what people are thinking about this particular case. What the person, or if anyone can even help us understand how.
This is my case that the team had sent me last week in Cox's in Ukiah. So I'm not sure which hospital sent this one, but I think just this probably talks about the point that you made, Michelle, and maybe you want to talk about more, just like almost a moral injury that happens, and this continuous moral injury. We've all been trained. We know that this is a surgery that can be done to the arterial switch and everything. So to see a child and know that they're not going to ever get that procedure, and is so hard. So so it's from OCB, from MSF OCB. They sent this one last week. So I don't know, just any more thoughts about like maybe how we approach that ourselves and how we reconcile that. And Rachel's raised her hand. She probably is there, just wants to say something about this case.
Rachel?
Hi there, everyone. I actually thought this maybe was a case from our hospital because we've had a very similar case and others that are similar as well. So one thing I was just going to add, so I'm the neonatology nursing activities manager at Guadalajara Hospital. One thing I would just add is that also one thing that I've noticed that can be challenging is when the patient is actually a Rohingya refugee, that we are sort of, at least at MSF, we're sort of reliant on the referral mechanisms through the organization and mechanisms that we've been able to establish through other organizations. But if the patient is Bangladeshi, sometimes there are theoretically options in Dhaka that are available to them. We sometimes will just share that yeah, it's really challenging, because I think sometimes with the Rohingya patients, we sort of basically say there is no option. And with the Bangladeshi patients, theoretically, there may be an option in Dhaka, but they have to travel on their own. And I feel quite uncomfortable sometimes with not knowing the quality of those surgical options, the outcomes, and also when you leave that possibility open, it's just, yeah, it's a very complex.
Yeah, no, this is truly terrible. And as I say, we this is like a surgery we do all the time. So it's and I think, thank you, Rachel, for sharing that, because again, I just, you know, I'm at this great distance, feeling heartbroken, seeing this, to be in your context where it might be, well, you know, if you're a Bangla baby, maybe, you're a Rohingya baby, no. And I don't, you know, the babies don't know what label's been put on their head. And it's just, it is. So I think this is a situation where absolutely the values we bring are affronted. It causes moral distress for sure. And we are at risk of moral injury in this. So, you know, what are we, well, first of all, and I know you do it, you're great scramblers, all of you try and find, how can we get this, let's see what Megan is saying here. Also that it's very difficult for Bangla babies as well to get, they won't all get the procedures. So it is writ large in your context, a very scarce resource. So what do you do? So first you scramble, but you have this, we need to manage this baby. I don't know what Rachel's saying here. Right, okay, and the pandemic has made everything on the planet horrible, as if it wasn't, you know, these situations weren't horrible enough. So that probably even reduces for anyone in your region, Bangladesh or Rohingya baby, all in low risk to be able to move forward. So you explore all the options, and sometimes all we can do ethically is, in a sense, process the heck out of what we're doing and just, you know, like kind of turn over all the rocks and see if we find something. Certainly on the day-to-day, we have to do our best to get to provide comfort for this baby and for the family, whatever that means. So yeah, so and in fact, Rachel just said to reduce suffering, and obviously morphine to reduce to support comfort and the effort of breathing is something. But also, I don't know in your circumstances how you are able to, but if you are able to involve the family in care, to be giving you know, kind of physical support and love to this child and connection, you would be doing that as well. And, you know, so you will get through this situation, and it's a wound. I think that's true. And I'm just saying here, sorry. Yes, it is. I think that yeah, we do need to, families need to know what's happening. And it's not that they don't understand the circumstances they're in, much as we would have it all be different. So this is truthfully a really morally distressful situation. But again, the one where I kind of early in my rubric, like, what is the gap between what you ideally and by virtue of your training and experience, you know, you could do or you want to do? What's the gap between that and the context in which you actually find yourself, you know, with a spoon and a flashlight trying to, you know, to give care? So could you advance the slide, Megan, please? So I just said that. So we need to know what that gap is, and it really does. It underlines these global social and health justice questions, and which I'm assuming is a huge foundation for why all of you are doing the amazing work you're doing. So it's not that you don't know this. And and I think important to recognize that potential for moral distress and injury. It's there, and how you mitigate it on a case basis. For these cases, you work within the context and you set possible goals. You keep turning over the rocks to see if there's something else. And beyond the case, and part of that's what you're doing here, by whoever put the case forward, how do we honor even the terrible things that you experience and see and bear witness to, by learning, by teaching, and by advocacy. And I think that those, I don't know if there are other magic solutions, but they are, I think, the beginnings of the kind of response against moral distress and moral injury. So bringing this case forward, bringing it forward to me, let's having this international discussion. Let's use these in teaching rounds. We honor what we can out of these small lives, and it's, but I'm not so foolish to think that this is not a weight that you carry, and I ask you to try and manage it so you can keep helping the next family, and that's really what the work is. So thank you so much for bringing this really quite heartbreaking case forward. I'm not sure, maybe we'll move to the next case. I think we only have a few minutes.
Yeah, I think we just have maybe 10 more minutes, if you are okay to stay, Michelle.
Yeah.
Do we want to do this one or the next one? Maybe I'll let you choose if you feel like there's one that's more relevant. We probably just have time for
I'm
one.
happy to speak, or maybe I'll just quickly say about this child, and then we'll move to the next case.
Sure.
Case, that some of the considerations would be, and we look at kinds of vulnerability. This is a family, an intersectional. This is a family who's poor. This is a family where I'm assuming there's other obligations to other children. They don't have the resources necessarily of hygiene for making formula, and there will not be the supports, and that the mother will be wearing this. So this is a thing where gender and class and circumstances all come together to make things very difficult. And I'll just move to the next slide to see what I quickly said about this. So, and again, this is why I'm skipping over this, and because some of the considerations of artificial nutrition and hydration are the same. So again, look at goals, look at the risks and benefits and burdens writ large, and writ large means like in a big sense. So that includes the burden, cultural considerations, and the role of women, and who disproportionately in healthcare situations can be burdened, not always, but that's not atypical. And then finally, how do we value and honor this young girl's life, again, by our reflecting on this, by teaching. And I would think, just about this case, I'd want to know more about her experience of feeding. It's still possible to take things by mouth, or even just, I've seen in a case with a young person with CP where they didn't pursue, there were so many problems with artificial nutrition, hydration, but the child loved having like fruit rubbed in their mouth and moisture in their mouth. And that was a child who was dying, but there are ways that we don't lose our creativity and our compassion in giving care to kids. So let's pop to the next slide. I think this was with an adult patient. Right, this is a pancreatic cancer management. So this was a 46-year-old with a pancreatic cancer and a mass in his epigastrium, severe pain. He was getting a lot of morphine as needed. He was using kind of self-use 12 times a day with minimal benefit. And I think it's really important that there's minimal benefit. Nurses were very concerned about his behavior because he was asking for morphine so often, sometimes several times an hour, and very agitated if there was a delay. When asked about this, and again, this is why we need people's stories, he said that he felt very anxious that the pain would increase again if he didn't receive his medication on time. Doctor was worried that the patient might be addicted, and the palliative care team and relatives wanted good pain control. So how will we manage this care team? And if we move to this next slide. So I will just say that it is, despite all the years of us knowing this, like narcotics in the end of life, there is a myth of addiction really on this, but in so many contexts, people are very afraid of, and for good reason, of these drugs, but not in this context. So I think that obviously we still have work to do on that. A really important question here is the intervention working? And sometimes, you know, there's this thing like, oh, that's not working, we'll give you more. It's a kind of a healthcare go-to. So a question for me would have been, what are the alternatives or perhaps supplements to this that might help with, I'll say his pain, but I'm thinking maybe his distress. And I was very struck by one of the other dimensions of comfort, of course, is fear. And he was afraid of pain coming back. And possibly this man is very likely afraid of dying, and he's afraid of what that experience is going to be. His fear of pain may arise out of previous experiences around trauma. We don't know what experiences people have had of physical violence, of pain, of torture. There are many aspects here. So I think we need to know this man a little bit better if possible, and see, are there other things that we can help address? Some of the fears, some of the anxiety, perhaps some spiritual needs. But whatever we propose, it needs to be doable. So this is really, you know, what is really the problem here? Whose problem is it? What are the goals and what are the contexts? So I see, Romana, that you have your hand up.
Yes, just wanted to add that, you know, when patient is seeking for, let's say, on opioid for some time for pain and seeking the medication, just assuming that that is really the case, patient is in pain and seeking the medication, and people around him can be worried if they're not counseled properly. We have learned, and we usually, what we do is we counsel the family that this is called therapeutic dependence. So what happened is, you know, end of dose need craving, and the patient knows that when this feeling comes, then the pain comes. So they're very scared, and then they seek out the medication. That doesn't mean patient is addicted or dependent. So the difference between dependence syndrome and therapeutic dependence, when we explain this, that, you know, I often say that it's like when someone has diabetes, they need insulin. So it's not that they're addicted to it, but they need it to get going at that point. You know, just an example. We can have different examples.
Yeah, no, Romana, thank you. That is actually a really, really helpful way to, I will use that, a really helpful way to understand that. And this is why we need to speak with patients and with families. So I appreciate that. I'm really mindful of the time. And I've gone over, I'm so sorry. Well, we'll get together again another time. Megan, do you want to maybe go to the wrap up slide? And you're going to get all these slides. So I just, you know, to say quickly, you're doing tremendously rewarding, but, you know, such challenging work, and you are all at risk of moral distress and moral injuries. But I think being aware of them and thinking about them as we have, you know, in our intense experience of working with patients and families, a realistic view of context, and your goals have to recognize the context you're in. And these things are complicated by the trauma and the intersectionality that are characteristics, I would think, of many of your patients and families. And how do we make sense out of all of it? I'll say again that we learn, that we teach, and we advocate. And you know, you help me by involving me in this to advocate for you, and I'll continue to do so in whatever way that I can. And do the next slide, Megan. And I just wanted to thank you all for your commitment and care to Healthy World. And it's been a shocking 18 months. I hope you're all taking care of yourselves. So I know we're at the end of time. Megan, please share the slides if people want them. And please let me know if I can, in the future, help out at all. Very pleased to do so.
Thank you so much, Michelle. It's been a really helpful experience, I think, for all of us. And with your permission, we will share the slides and the recording, which is a private recording just for the participants, in case anyone wants to rewatch. I'll just hand over to Romana and and Tasneem for the final words.
Thank you, Dr. Mullen. You know, you have wrapped up very nicely all the aspects of ethical discussion. It was simple but very informative, and we especially enjoyed the case discussion. And you can't see me. I couldn't start the video for some reason. Okay, so so I think from this and from the discussion that we can see in the chat, it's been a very useful topic and very important topic for us to learn. And I think one lecture is never enough for ethics. Megan, you'll agree. You know, there are so many little things that we need to go into, you know, autonomy, beneficence, all of it, justice, and all the 4 principles and scope of it. We really need to go into it more and understand more. So this is a very nice overview. We are looking forward to meet you again, Dr. Michelle Mullen, and maybe we will discuss more and share our you know, thoughts and dilemmas with you. Thank you so much. I'm sorry, I don't know why video is not coming on. It says
Thank all
host
of
has.
you. And thank you, Romana, so much. You know, maybe we could do some case rounds. Megan and I will talk. We'll work something out. This is the good thing that came from the pandemic, is that we all know how to use Zoom now.
Zoom, yes, because you know, withdrawing and starting feeding is one area which is very important. And
yes.
I've been in ethical dilemma myself, you know, sometimes there has been critical issues. But thank you so much to bring in, and I learned few things today. The cognitive dissonance, for instance.
All right, lovely. Goodbye. Take care, everyone.
Bye-bye.
Thank you so much.
Thank you so much.
The Bangla summary is not done yet.
Okay, we'll do a Bangla summary, Michelle, but you're welcome to to leave before then.
All right.
I just heard so much.
Thanks.
No, I'm here. I'm saying bye to Michelle.
Yeah. So if the participants want to stay, we'll do a Bangla summary now.
Tasneem is very worried. Yeah. Please do.
Ma'am, I just want my people to get it 100%. That's the only thing from my end. Roshanapa is having some issues with her network, so I will do that. Is that okay, ma'am?
Please go ahead.
Thank you.
Tasneem, please.
আসসালামু আলাইকুম, বাংলা সামারিতে আপনাকে স্বাগতম। আমরা আজকে প্যালিয়েটিভ কেয়ারে ইথিক্যাল কনসিডারেশন কি কি হতে পারে বা চ্যালেঞ্জ কি হতে পারে সেই বিষয়ে একজন বিজ্ঞ ব্যক্তির কাছ থেকে লেকচার পেয়েছি। আমি খুব ছোট করে বলার চেষ্টা করব আমরা আজকে কি কি শিখেছি সেই বিষয়ে। ওনার প্রথম স্লাইডটি ছিল এজেন্ডা বিষয়, যেখানে আমরা একজন মানুষের প্রতি কিভাবে সম্মান দেখাতে হয়, অবশ্যই তার কোনো ক্ষতি না করে, এবং জাস্টিস আমরা যে কথাটা বলি যে এটি আইনসম্মতভাবে ঠিক আছে কিনা, সুবিচার হচ্ছে কিনা, সেই ব্যাপারগুলো নিয়ে আমরা শুনেছি। আমরা আরো কিছু টার্ম শিখেছি আজকে। একটি ছিল ইন্টারসেকশনালিটি এবং অন্যটি ছিল ট্রমা ইনফর্মড কেয়ার। ইন্টারসেকশনালিটির বাংলা হচ্ছে ছেদ করা। এরপর আমরা অনেকগুলো একটা স্লাইড দেখতে পেয়েছি যেখানে অনেকগুলো বিষয় উল্লেখ করা ছিল। খুব মোটা দাগে বলতে হবে যে আমরা একজন রোগীর ক্ষেত্রে তার ন্যাশনালিটি, বয়স, কালচার, সে দেখতে কেমন, তার শিক্ষাগত যোগ্যতা কি, সে কোন ভাষায় কথা বলে, এইটার একটার সাথে আরেকটা জড়িত হয়ে তার ক্ষেত্রে আমরা যে কেয়ারটা দিব সেটা কোনোভাবে ব্যাহত অথবা কারো ক্ষেত্রে কম, কারো ক্ষেত্রে বেশি হচ্ছে কিনা। আরো একটা বিষয় আমরা শিখেছি, সেটা হচ্ছে যারা অলরেডি একটা আঘাত পেয়েছে, ট্রমা ইনফর্মড কেয়ার, তাদের ক্ষেত্রে আমাদের এই ইথিক্যাল ইস্যুগুলো কিভাবে আসতে পারে। আমাদেরকে একটা চেকলিস্টের কথা বলা হয়েছে যেখানে 4টা আর বলে দেওয়া হয়েছিল: রিয়েলাইজেশন, রিকগনিশন, রেসপন্ড এন্ড রেজিস্টিং রিট্রমাটাইজেশন। এটা বাংলায় বললে হবে যে প্রথমত বুঝতে পারা তার সাথে কি হয়েছে, কি আঘাতটা সে পেয়েছে, দ্বিতীয়ত হচ্ছে সে আঘাতটাকে চিহ্নিত করা এবং সেটার প্রতি সাড়া দেওয়া, জবাব দেওয়া বা উত্তর দেওয়া, এবং পরবর্তীতে যেন আমার দ্বারা এ ধরনের কিছু না হয় সেই ব্যাপারটা নিয়ে চিন্তা করা। আমরা আবার যখন চেকলিস্টের ব্যাপারে আরো কিছু বলেছি, সেক্ষেত্রে হতে পারে যে আমাদের কাছে এই সমস্যাটা সমাধান করার জন্য আদর্শ কোনো উপায় রয়েছে কিনা, এবং সেই উপায়টি আমরা যে জায়গাটিতে রয়েছি সেটির সাথে যুক্তিসম্মত কিনা। আবার আরো একটা ব্যাপার হতে পারে, আমরা যদি এই প্রবলেমটাকে সলভ করতে চাই তাহলে আমি অন্যদের কাকে সাথে নিব, এবং আমার ভ্যালু এবং আমার যে অভিজ্ঞতাটা রয়েছে সেটা কি এই বিষয়টাকে অন্যদিকে নিয়ে যেতে পারে কিনা। আমরা খুব সুন্দর একটা ছবি দেখেছিলাম, সিকিউর ইউর ওন মাস্ক ফার্স্ট। বিমানে ওঠার পর যেটা হয় সেটা হচ্ছে নির্দেশনা থাকে আপনি আগে নিজের মাস্ক পরবেন, তারপর আপনার পাশে যিনি রয়েছেন, ছবিতে দেখানো ছিল একটি শিশু রয়েছে একজন মহিলার পাশে, কিন্তু ওনাকে আগে নিজের মাস্কটি পরতে হবে, তারপর শিশুকে তিনি পড়াচ্ছেন। আমরা আরো একটা শব্দ শিখেছি, সেটা হচ্ছে মোরাল ইনজুরি বা নৈতিক দিক থেকে আঘাতপ্রাপ্ত হওয়া। এইটা কিভাবে হতে পারে, এটাকে বলেছে যে সাইকোলজিক্যাল ডিস্ট্রেস। এটা এক ধরনের সাইকোলজিক্যাল ডিস্ট্রেস হতে পারে, যেটা একজনের ব্যক্তিগত যে মতামত আছে সেটার সাথে সাংঘর্ষিক হতে পারে। অবশ্যই এটিকে আঘাত পাওয়ার পরের অবস্থার সাথে তুলনা করা হয়নি। এরপর আমরা আরো একটা শব্দ শিখেছি, সেটা হচ্ছে মোরাল ডিস্ট্রেস এবং মোরাল ইনজুরি। আমরা দুটো শব্দ শিখেছি এখান থেকে, এবং মোরাল ইনজুরির ক্ষেত্রে খুব সুন্দর করে একটা শব্দ এসেছে, সেটা হচ্ছে কগনিটিভ ডিসোনেন্স। যদিও আমার ম্যাডাম একবার ব্যাখ্যা করেছেন, তারপরও আমি বলবো কগনিটিভ ডিসোনেন্সের খুব সুন্দর একটা এক্সাম্পল দেওয়া হয়েছে। নিউ ইয়র্কে ইঁদুর মারার কল যখন আবিষ্কৃত হয় 1900 সালের মাঝামাঝি সময়ে, তখন ইঁদুরদেরকে ট্রেন্ড আপ করা হয়েছিল কলে আসলেই তোমাকে খাবার দেওয়া হবে। পরবর্তীতে ইলেকট্রিক শক দিয়ে এই ইঁদুরগুলোকে মেরে ফেলা হয়। ব্যাপারটা এরকম, এটা মানুষের ভালোর জন্য করা হচ্ছে বা সায়েন্টিফিক ভাবেই ওনারা এই জিনিসটা উদ্ভাবন করেছেন, কিন্তু তারপরও খারাপ লাগা কাজ করছিল যে আমরা খাবার দেওয়ার জন্য কাউকে এনে তারপর তাকে কলে দিয়ে মেরে ফেলছি। এই জিনিসটাকেই বলা হয়েছে, বাংলা এটার খুব সুন্দর বাংলা হচ্ছে জ্ঞান পাপী বা জ্ঞানের আধিক্য। আপনার জ্ঞানটা আছে যে কি করছি বা এটা সঠিকভাবে করছি কিনা, কিন্তু হয়তো বা এই মুহূর্তের জন্য এটাই সঠিক ডিসিশন। আমরা কিছু কেস দেখতে পেয়েছি, আমি যদি ভুল না করি প্রথম 3টা কেসই ছিল শিশুদের সংক্রান্ত। প্রথম কেসটা আমার কাছে খুব ইন্টারেস্টিং লেগেছে। 650 গ্রাম ওজনের একজন বাচ্চা, যে 24 সপ্তাহে জন্মগ্রহণ করেছে, এবং আমরা শুনেছি যে এই বাচ্চাটাকে কি আমরা আর্টিফিশিয়াল ফিডিং দিব, আমরা কি তাকে আইভি ফ্লুইড দিব, অথবা আমরা তার জন্য কি কি করতে পারি। আমরা এরপর দেখেছি কনসিডারেশন, কি কি উপায় অবলম্বন করা যায়। আমাদের একটা সহজাত প্রবৃত্তি হচ্ছে শিশুকে খাবার দেওয়া, সেটা বেশিরভাগ কনটেক্সটেই ক্ষেত্রেই খাটে, এবং আমরা ইনবক্সে দেখতে পেয়েছি এমএসএফ গোয়ালমারাতে কাজ করছেন এরকম একজন কলিগ কমেন্ট করেছেন, ইরিন কমেন্ট করেছেন কেনিয়া থেকে, কালচারাল কনসিডারেশন অথবা কিভাবে কমফোর্ট দেওয়া যায় সেই বিষয়ে। এরপর আমরা দেখেছি কনজেনিটাল হার্ট ডিজিজ নিয়ে একজন বাচ্চার ব্যাপারে বলা হয়েছে। সেই ক্ষেত্রে আমাদের পটেনশিয়াল বা মোরাল ডিস্ট্রেস কিভাবে কাজ করে, কনটেক্সট অনুযায়ী আমরা পসিবল গোলের দিকে কিভাবে কাজ করব সেই সংক্রান্ত উপায়গুলোতে। এবং কেস 3 যে কেসটি ছিল সেরেব্রাল পলসি, সেটার ক্ষেত্রেও আর্টিফিশিয়াল নিউট্রিশন নিয়ে বলা হয়েছে। আমরা কোনো ঝুঁকির ভেতরে ফেলছি কিনা, এটাতে কি কি উপকার হতে পারে এবং বার্ডেন কি হতে পারে সে নিয়ে আমরা কথা বলেছি। এবং শেষ বিষয়টি ছিল হচ্ছে একটি ছোট মেয়ের ক্ষেত্রে ভ্যালু এবং অনার প্রদান করা, সম্মান প্রদান করা, যে তার জীবন শেষ হতে যাচ্ছে। লাস্ট কেস ছিল প্যানক্রিয়াটিক ক্যান্সারের পেইন ম্যানেজমেন্ট নিয়ে, এবং আমরা কিছু মিথ নিয়ে কথা বলেছি। আমরা যদি মরফিন দেই সেক্ষেত্রে রোগী মরফিনের প্রতি অ্যাডিকটিভ হয়ে যাবেন কিনা। বাংলাদেশের পার্সপেক্টিভে, স্পেশালি আমি যেখানে কাজ করেছি রোহিঙ্গা ক্যাম্পে, মরফিন সংক্রান্ত যে কথাগুলো শোনা যায় যে এটা দিয়ে রোগীকে অ্যাডিক্টেড বানিয়ে দেওয়া হচ্ছে কিনা, এই ব্যাপারগুলোতে বলা হয়েছে। লাস্টলি আমাদেরকে বলা হয়েছে আপনারা যে কাজটা করছেন এটা রিওয়ার্ডিং এবং চ্যালেঞ্জিং। মোরাল ডিস্ট্রেস, মোরাল ইনজুরি এগুলো হিউম্যানিটেরিয়ান কনটেক্সটে যারা কাজ করেন তাদের ক্ষেত্রে অনেক বেশি থাকে। মনে হয় যে অনেক কিছু করতে পারতাম কিন্তু এখানে থাকার জন্য করতে পারলাম না। আপনার গোলগুলোকে আপনাকে আগে চিনতে হবে। কমপ্লেক্সিটির ভিতরে ট্রমা এবং ইন্টারসেকশনালিটি আসতে পারে, এবং আমরা যেটা করতে পারি সেটা হচ্ছে আমরা শিখতে পারি, আমরা শেখাতে পারি, এবং এই কেসগুলো নিয়ে আমরা অ্যাডভোকেসি করতে পারি যে আমরা কি ধরনের কেস পেয়েছিলাম, আমরা কিভাবে আমাদের কনটেক্সট থেকে এটা নিয়ে ব্যাখ্যা করেছিলাম বা কাজ করেছিলাম। ধন্যবাদ।
থ্যাংক ইউ ভেরি মাচ, অনেক ধন্যবাদ তাসনিম তোমাকে খুব সুন্দর অনুবাদ করার জন্য। কারো কোনো প্রশ্ন থাকলে আমরা একটা হয়তো প্রশ্ন দেখতে পারি, আর প্রশ্ন না থাকলে আমরা এবারের মতো শেষ করব। আবার
এরকম একটা
আগামী
পোস্ট দেখতে পাচ্ছি এথিক্স ফলো আপ নিয়ে, যদি একটু বলে দেন।
পোলটা কই? রাইট, পোলটা সবাই অ্যাটেন্ড করেন। Would you like to have another session to say yes?
আপনারা যদি এই ইথিক্যাল সেশনের উপর আরো একটি সেশন বা এর চেয়ে বেশি সেশন দেখতে চান, তাহলে দয়া করে ইএস এর উপর ক্লিক করেন। ইএস এর উপর ক্লিক করলে আপনার ভোটটা অটোমেটিক চলে আসবে পুলে। থ্যাংক ইউ ভেরি মাচ।
থ্যাংক ইউ স্যার। আমি এটুকু বলতে পারি যে এথিক্স এর উপর যথেষ্ট আমরা লেকচার শুনি বা দেখি, বাট মিশেল মেলন কিন্তু খুব সুন্দর কিছু পয়েন্টস নিয়ে এসছেন যেগুলো আমাদের জানা উচিত এবং আমাদের আসলে প্রয়োজন হয় এই ডাক্তারি জীবনে বা হেলথ কেয়ার যখন প্রোভাইড করি, এটাই খুব ইউজফুল। সো আমি মনে করি আরেকটা হলে ভালো হবে, আমার ধারণা। অনেক ধন্যবাদ সবাইকে। মেগান, can we close then?
Yeah, we can close. And
Okay.
I'll just say that our next mentoring session will be in, I think it's in 3 weeks. And the topic is going to be something on pediatric palliative care. And it will be based probably around similar cases. Actually, we'll actually go to these cases and look at them in more detail and tell you about what happened for these patients and how we did the care. So that's our plan.
Thank you very much. Tasneem, anything you want to add?
No, ma'am, thank you. Thanks for your excellent
Okay.
facilitation.
Yeah, and
My
for batch
pleasure.
3, there's a session next week. But if you're not in batch 3, then the next session is in 3 weeks. Sorry, just to not so people aren't confused.
Yes. Almost 47 of us are there. So yes, looks like we want a session on ethics. Done. Thank you very much for that. Looking forward to see you again on Friday, right? Okay. Bye-bye.
Bye, everybody. Have a good week. Balo taken. Aberdeka hobi.
Bye, Erin.
Allah. Oh Allah. Allah.